Hi, everybody. This is Dr. Yamal Patel again from Third Park Hospital in Nairobi, Kenya. Today, we're going to be discussing about planning an endometriosis surgery. We'll be doing this talk in two parts because it's a very vast discussion. How do we plan an endometriosis surgery? Part 1. So we know classification of endometriosis is basically into three major groups. The superficial peritoneal endo, the ovarian endo, and the deep infiltrative endo. What is deep infiltrative endometriosis? As per the definition, it is endometrium-like tissue which is outside the uterus and with a depth of more than 5 millimeters. A few things of note is this infiltrates abdominal and pelvic parietal peritoneum with associated inflammatory and fibrotic changes. It also infiltrates visceral organs and causes resultant retraction of these organs. It does distort the anatomy, and there is loss of planes that are seen in deep infiltrative endometriosis. What are the issues with deep infiltrative endometriosis surgery? This is very important to understand. It is very complex. It is risky, that is prone to many complications potentially, visceral injury, sepsis, nerve injury, a major bleed, etc. It is long and exhaustive. There are anesthesia risks, there is risks of DVT, infection risks increase, and it's also fatigue-related issues with the surgeon that are associated in this surgery. It is very expensive in view of what is required and the duration and some of the expertise that may be required. It is very likely, in many times, incomplete unless done properly by an endo specialist. There is a risk of symptom persistence in many of these patients, especially when it is more of the conservative surgery. There is a risk of recurrence. So it's important to know the difference between recurrence and residual disease. Recurrence is, yes, we cleared as much as possible and there was a new formation of the disease. Whereas with residual disease, it's because there is quite a bit of the disease that was left back if it was not excised in total with the nodules. And it's important to understand that DIE surgery is a multi-organ involvement surgery and therefore possibly a multidisciplinary team involvement surgery. So when we are prepping for DIE surgery, the questions to ask ourselves is, where will we do it? Who will do it? When do we do it? And how do we do it? Now, we should ask these questions every time we're prepping a patient for DIE surgery. So let's start with the evaluation or the how. We need a full extensive evaluation preoperatively involving the history, involving a complete validated symptom questionnaire, past treatments, medical morbidities involved or discussed, do a proper abdominal, pelvic, bimanual, and rectovaginal examination, follow it up with imaging, especially if possible, a detailed targeted DIE transvaginal scan, where feasible, if not a transrectal scan, and classify this disease. When it's not possible, then we can also work on a detailed MRI of the pelvis and upper abdomen to assess and classify the disease. Then we need to understand what is the main treatment goal that this patient is trying to achieve. Is it pain? Is it quality of life? Is it psychosocial? Is it fertility? What is it that the patient is seeking advice for? We may need to do a few baseline pre-op workup, including possibility of a baseline ovarian status, where we are checking the ovarian reserve with the AMH, Very important, especially if fertility preservation is desired. We need to understand a few things about past history of surgery that the patient may have had, because very many of these patients will actually present to us with history of previous surgeries for the endometriosis. It could be open surgery, it could be laparoscopic surgery. So what do we need about surgery? We need the number of surgeries. We need to know whether it was open or laparoscopic. We need to know if there was any photo or video recording of the surgery to understand the extent of the disease. We need to know if there was ovarian surgery, and if so, was it unilateral or bilateral ovarian surgery? We need to know if previous retroperitoneal surgery has been done. Was ureterolysis done? Was bowel surgery or bowel, pararectal dissection done? Was it complete or not? Was there a complication during that surgery? And was there any evidence of post-op medical treatment that may have been given to this patient? So this is very important to understand about past surgery. We also have to discuss the role of pre-op possible IVF and ovum pickup and possible cryopreservation of either the gametes, which means the ova, or possible frozen embryos for cryopreservation, which really enhances outcomes of these patients in the fertility field, because it's likely that these surgeries lead to ovarian reserve decline, and it will therefore give us more freedom to do a complete surgery if we already have some frozen embryos kept aside. We need to understand the fertility desire, whether it's immediate or remote, about the patient. Next question, where? So ideally, an endometriosis center would be good, where you have the full complement of an endometriosis gynecological minimal invasive surgeon, an infertility specialist, a colorectal colleague, a urologist, vascular surgeon when needed, a thoracic surgeon, a nursing specialist for endo, physiotherapist and a psychotherapist, gastroenterologist, pain specialist, and a support group backup. So this is an ideal endometriosis center where such patients should be operated on. Have the right team, the multidisciplinary team, very important. Ideally, it should be a one-stop, right from diagnosis to treatment to follow-up. And do they have the right equipment for this kind of extensive endometriosis surgery? So that's how we select where. Let's decide on the who. The who, ideally, it should be an endometriosis excision specialist who is an advanced gynecological minimal invasive surgeon. He should also have reproductive surgery skills. So a reproductive surgeon, very important, because we're talking of possibility of fertility preservation or enhancing techniques. And he should be a surgeon who has transversal competencies and a thorough knowledge of anatomy of the region that is in the pelvis, both in skill and in knowledge. But yes, he should also be backed up with the full complement of the multidisciplinary team. So pre-op classification, my way of doing it is I use the Enzian ultrasound classification by doing the IDEA consensus, following the IDEA consensus using the transvaginal scan. And I have used the transrectal scan for the similar staging or classification of the disease in Virgo intacta women and girls. It's important to have location of all the DIE lesions. So you have to go step by step, not missing any. Focus on the uterus, the ovaries and the tubes, the pouch of Douglas, the bladder, the ureters, the bowel, the dorsolateral component with the uterosacrals and the torus, and the parametrium. Obviously, further depth into the sacral nerves area is also being done nowadays to understand the extent of the disease. Always make sure the ureters and the kidneys are assessed in every patient with deep infiltrative endometriosis. And I use the MRI for extrapelvic disease whenever needed. So if I'm looking at the ileocecal area or the small intestines for that matter, or possibly even diaphragmatic, I would rely on the MRI. And let's use terminologies relating to the idea, the MUSA, the IOTA, and the IETA classification to describe these lesions. If hydronephrosis is found, what is the next step? The next step would be to consider a CT KUB, an IUVU, so CT intravenous urogram would be important. The detailed TVS obviously has been done. Possibility of a renal scan to check on the functionality of this kidney is important. Basic kidney function test, the urea, creatinines, and the electrolytes. The bladder should ideally be assessed preoperatively, and if possible, an intra-op cystoscopy is very important. And make sure in this scenario, the surgery is planned with a urologist, MDT team member, who should be informed and ready should his need arise. What if we found a bowel nodule? When a bowel nodule is found, the number of lesions, the size in 3 dimensions, the depth of the lesion, the location of the lesions, a single multifocal or multicentric description of the lesions is important. Distance from the anal verge, very important. Circumference of the lesion, so what's the circumference of the lumen of the rectum involved, if possible, and whether there is stenosis of the lumen or not, very important. Now, we've decided to move ahead with the surgery. The next discussion would be about the informed consent. The informed consent for DIE surgery should be very detailed, explaining all the findings of the scan that has been done. It should be procedure specific. So when we are discussing endosurgery, it should be procedure specific. What do we plan to do for possibly the bowel? What do we plan to do for the uterus if there's adenomyosis? What do we plan to do for the ureters if they're involved? What do we plan to do for the bladder if it was involved? So it's procedure specific. It should be relevant. The extent of the planned surgery should be discussed. The benefits expected should be discussed. The potential risks and complications have to be mentioned. And the alternatives, their pros and cons should have been mentioned or discussed with the patient and the family. Short-term and long-term consequences, benefits, as well as outcomes should be expected and discussed, including recurrence risks, including sometimes symptoms persistence in some cases should be discussed. Issues with omitting the surgery should be obviously mentioned, that it's likely to lose a kidney if there's already changes in the ureter, for example. And patient info leaflets and resources should be given to the patient to probably do their research and evaluate further about it. And this should all be done in a language that is well understood and mutually signed and agreed on by both parties. The decision making should be collective. It should never be pushed onto the patient by the surgeon. Most of these patients are suffering quite a bit, and many of them would obviously be willing to take all the risks that it could encounter, possibly because of what they're going through anyway. But it's important that the decision is collective. Arrange and now inform the multidisciplinary team. Ensure that the correct place and equipment, instrumentation is ready. In some cases, it's necessary to plan preoperatively a multidisciplinary board meeting to plan the surgery or the treatment plan. And if bowel surgery is planned, then bowel prep might have to be discussed. I have been using mechanical bowel prep with intraluminal antibiotic decontamination procedure. So let's have a few basics now about the actual surgery. And then probably end it up as we go into the nitty-gritties of the individual areas, but that will be covered in part 2. But for now, the basics about DIE surgery. Number 1, the dictum should be laparoscopy, not laparotomy. I repeat, laparoscopic surgery for deep infiltrative endometriosis, not laparotomy. Excision, preferable to ablation. If we don't excise the fibrotic nodules and lesions, there is no way the symptoms will improve. So it's not possible to ablate. And when you ablate, you may be ablating only the tip of the iceberg, leaving majority of the disease still inside. Another dictum is taking off is an option, landing is compulsory. If you go in and assess in overall how the disease in the pelvis is, before you take off that flight to proceed with the surgery, make sure that you have the correct skill, knowledge, experience, and a backup team to complete the landing. Otherwise, it's better to halt and let someone else take over that flight. A thorough knowledge of the retroperitoneal anatomy and the possible neuropelviology is very vital for DIE surgery. Keeping in mind that we have to be radical to disease but conservative to function is extremely important. And wherever possible, nerve sparing should be kept in mind to avoid long-term issues with nerve injury in the pelvis. The goals of DIE surgery could be fertility, could be pain, could be quality of life, and the mutual decision should be reached to understand how to proceed with this surgery. Keep the patient first and follow the preference of the patient and do symptom-based surgery. So don't treat a patient if she's not come seeking for help for that problem. And be able to have transversal competencies. Are there any specific instruments that are required for DIE surgery? Well, it's good to have in the armamentarium for DIE surgery, within the theater, a rectal probe, which sometimes is needed, bulldog clamps for possible vascular injury and related issues, ultrasonic device so that we can use it for the dissection process, but you can use bipolar and scissors, you can use the bipolar shears, you could use the ultrasonic shears, but it's good to have these special instruments around. Staplers may be needed when you're going to consider bowel surgery. Stents could be required for the ureter if we are too close or we have an injury on the ureter, or we have a ureteric repair that is done. Cystoscope may be needed. Advanced energy is important to have in the backup. A uterine manipulator, which can allow very good anteversion and retroversion, is important. And instruments for bowel and adnexal suspension and uterine suspension might be useful to give us access to the pelvis. So, what are the conflicts in the mind of a DIE surgeon as we start contemplating doing a surgery for deep infiltrative endometriosis? Number 1, complete excision versus preservation of organs and nerves. So that is very important. The concept of limited radicality. So you can't be extremely radical and injure nerves as you go around and leave the patient with nerve injury deficit symptoms. But you also don't want to leave the disease. So very important to have limited radicality. Another conflict could be when you are having to deal with bilateral endometriomas. Very important, because if you handle these bilateral endometriomas, kissing ovaries, in a rough way, then you may end up damaging the patient's ovarian reserve and subsequent fertility outcomes significantly. So be extremely wary in bilateral endometriomas and consider lesser invasive or damaging procedures like possible sclerotherapy or just superficial ablation of the cyst wall as opposed to a cystectomy in such patients. Multi-organ involvement is important. It's a conflict in the mind of a DIE surgeon. What will I find? Which organs are going to be involved? So very important to have this done preoperatively if possible. Whether to stent or not is a dilemma sometimes. So, I mean, it's something that will come with experience. What type of bowel surgery to do? Am I going to manage shaving? Am I going to manage a discoid excision? Or will we need a resection and anastomosis? So this is, again, with certain guidelines that we can follow to decide on which of these three options might work better. But wherever possible, I try and be conservative because the outcomes are definitely more better, though there is a risk of occasional residual disease remaining on the bowel. But do they really cause symptoms? Is fibrotic nodule really a progressive disease or already an end-stage disease? Is it likely to cause progression of the stenosis if we have removed majority of the other disease? These are questions to answer that are always conflicting in the mind of the DIE surgeon. Another conflict or challenge or dilemma is whenever we're dealing with repeat surgery. So when we're going into a patient with repeat surgery, and God forbid it be an open previous surgery, a laparotomy, then we have lots of other issues to deal with, adhesions and fibrosis, to top up the already complex DIE surgery. A dilemma: can I land the plane? So that's something that only experience will teach you. And if you can't, then, as I've said, work together with a team who has collectively the ability to land the plane. And do I have the team of backup ready? So this is how a surgeon who is planning a DIE surgery is going to be having all these dilemmas. Let's move to patient positioning. For long DIE surgery, TED stockings or possible intermittent pneumatic compressions might be useful. Prevention with low molecular weight heparin prophylaxis, very important. A body warmer may be needed. Modified lithotomy, which is a Lloyd-Davis position, very important. So if you have the Allen stirrups and you manage to give the patient a Lloyd-Davis modified lithotomy position, it would really help. Arms, hands by the side, tucked in, as opposed to on the side, straightened out, because you need space by the side to have the surgeon move around. And if possible, we will definitely need a Trendelenburg later. So if possible, a non-slip mat or some braces to make the patient not slip, very important. So as we start, ideally, it's good to go and do a rectovaginal exam before the surgery, after anesthesia and after positioning, because the patient is now relaxed, and assess the nodularity, the mobility, and if possible, consider vaginoscopy to assess the posterior fornix to see if there is disease infiltrating through. Antibiotics may be needed, obviously, at the start of the procedure. Deliberate inspection and documentation of the whole abdomen on entry is essential, and preferably in a flat position before the Trendelenburg is given. After that, the port placement should be as per the anatomical situation and surgical need, and keeping in mind that you have the uterine, the vaginal, and the rectal setup ready in case of need. So for the uterine, you have an elevator or a manipulator put in already. For the vagina, you may need a sponge on a holder in the posterior fornix, and you may need a rectal probe within the theater for the rectum. Caution: be extra careful in patients with previous surgery, and especially if there is previous cystectomy as well. Be extremely worried about damage to that ovary. Previous ureterolysis is almost always very dangerous and risky, and it might have had some damaged ureteral vessels. So even with a very cautious and meticulous repeat ureterolysis, some risk of ureteral ischemia might be possible. So be very, very cautious in a repeat ureterolysis. Previous bowel dissection and surgery plus or minus shaving would mean that the bowel wall may be compromised already, and the risk of bowel injury or a fistula becomes higher. So this is caution. Always be cautious about, always make sure that the diaphragm has been examined laparoscopically, but keeping in mind that the transumbilical scope usually explores only the ventral part of the diaphragm. So you may not be able to see below or behind. So lesions behind the liver in the hepatophrenic cul-de-sac usually are difficult to assess without mobilizing the liver, but that needs to be done as well, so that we can be able to know the extent of the disease on the diaphragm. So to wind up this part 1, we'll be discussing the principles of DIE surgery, and then part 2 will cover up the individual areas of DIE surgery. So part 1, identify all important structures as we proceed. Very important. Identify all important lesions. So get all the lesions in map. Always start with easy steps first. Another way is to say that start from the known to the unknown, or the unaffected towards the affected, or lateral towards medial. So all these similar but easy steps first. Have optimal exposure with the manipulator, possible ovarian suspension, ovariopexy, additional ports if we have to put in, doesn't matter. Start with adhesiolysis and anatomy restoration. Free and isolate the lesions first, and only then go for the complete excision of the lesions. Do not start attacking the lesions directly. First surgery should be the best surgery. So if possible, avoid repeated surgeries whenever necessary. It's not always going to be possible, but whenever possible, give the best in the first surgery. Proceed if complete surgery is likely. So if an extensive incomplete surgery is done, then a reoperative surgery will be extremely difficult and sometimes even almost impossible because of the risks involved. 3D laparoscopy definitely adds value to the DIE surgery. The depth perception, the precision really changes when we are doing endometriosis surgery in 3D. Keep in mind microsurgical principles, and robotic assistance could add value to DIE surgery as well. So we'll start with the strategies for DIE surgery, dividing them into general strategies and lesion-specific strategy. And with this, I think I will probably end, because this will come into the part 2. So please follow and watch for the second part of DIE surgery, the principles and the strategy for deep infiltrative endometriosis surgery. See you next time. Have a good day.